Good day. My name is Dr. Fred Foley, and I'm the Director of Neuropsychology and Psychosocial Research at the Holy Name Medical Center's Multiple Sclerosis Center in Teaneck, New Jersey, and also a Professor of Psychology at Yeshiva University in the Bronx, New York. I'm here today to talk with my colleague about cognitive changes in multiple sclerosis.
And I'm Dr. Nancy Chiaravalloti. I'm the Director of Neuropsychology and Neuroscience at Kessler Foundation in West Orange, New Jersey. And I'm also a professor at Rutgers University in the Department of Physical Medicine and Rehabilitation. I've been conducting research in MS and cognition for the past 15 years, and I'm happy to be here to talk about cognitive changes and cognitive rehabilitation in persons with MS.
So Nancy, could you tell us a little bit about cognitive problems in multiple sclerosis? How often do they occur? And what kinds of cognitive changes can occur with MS?
Well, cognitive changes are actually very common in patients who have MS. Historically, we've thought that only 3% of persons with MS have cognitive issues. But what we're learning as the years go on is that up to 70% of the population struggles with cognitive problems. So that's a very large percentage of patients who are dealing with cognitive problems in their daily life. These cognitive problems span processing speed, working memory, learning and memory. There are some patients who have some difficulties with attention or executive functioning challenges, although those two are less common than the first three I mentioned.
You just mentioned a number of cognitive changes that occur. Could you tell me, what does information processing speed mean and working memory mean? How can we understand those terms a little more clearly?
Sure. Well, by far, information processing speed is the largest deficit that we see in patients who have multiple sclerosis. And what that means, information processing speed refers to the amount of time it takes to process a certain amount of information. So if you have slowed information processing speed, what that means is that when you're processing information, you're processing it more slowly than someone else, or more slowly than the way you used to previous to having the illness. And that has a significant impact on other aspects of daily life and other aspects of cognition. Working memory is similar. When we talk about working memory, what we're talking about is maintaining and manipulating information in your mind. So if you have to remember a phone number, that's maintaining information in your mind. That's basic working memory functioning. If you have to figure out the sale price of an item, that's manipulating information in your mind. So that would be the manipulation aspect of working memory. Similar to processing speed, those two functions form the basis of other aspects of cognition. So if you're having difficulty with either one of those functions, that can cause a major problem when it comes to learning and memory or executive functioning and even activities of daily life.
Which of these problems seems to be most prominent in MS?
Processing speed impairment is the most prominent cognitive problem in MS. And what we're finding in the work that we're doing is when someone has a difficulty with processing speed, they also have difficulties with other aspects of cognition. So a processing speed impairment may actually lead to difficulties with learning and memory or with executive functioning. The other thing that occurs is when someone has a significant processing speed problem, that problem can manifest itself in daily life. So they may have difficulties doing things quickly or in a timely fashion in their daily life, such as finding a recipe in a book and following along in a recipe, or finding ingredients on a food can, or making change if they may be a store clerk. All of those processes are slowed, and that could significantly impact their ability to function in their daily environment.
You mentioned that these problems occur in up to 70% of persons with MS. How severe do these problems get? And is this different from the kinds of cognitive problems that occur in, like, Alzheimer's disease?
Good question. It is different. The cognitive problems that we see in MS can start out very subtle. So in early relapsing remitting MS, patients may show no cognitive problems. As the disease progresses, it may develop over time. And then they may talk to their physician about difficulty. Usually their report is that they're having difficulty remembering things. And then it's the job of the neuropsychologist to figure out, is it indeed a memory problem that they're having, or are they having issues with their memory due to a processing speed impairment or a working memory impairment or an attention impairment? as the disease progresses, the cognitive impairment doesn't always have to progress, although it often does. So as patients move into secondary progressive MS, they may develop more significant cognitive impairments. Primary progressive MS also has cognitive impairments associated with it that are more significant than what we see in relapsing remitting MS. What's important to remember about MS is that it's very heterogeneous. So each patient really has to be individually assessed to identify that particular patient's strengths and weaknesses.
What is the relationship between cognitive impairments and disability? Can you be disabled physically but still be cognitively okay?
Another great question. Cognitive impairments do not always correlate with physical disability. So someone may have significant physical disability to the point of being in a wheelchair much of their day, and they may have no cognitive problems whatsoever. The opposite may also be true. Someone may have significant cognitive disability as well as significant physical disability. An individual may have significant cognitive disability but very little physical disability. Again, in MS, it's an extremely heterogeneous population, so each person really has to have a complete assessment on his or her own, and that person needs to be evaluated for their own strengths and weaknesses as well as their points of disability and their points of independence.
We've been learning more and more in recent years about the natural history of multiple sclerosis, particularly with the different courses of MS. Can you tell us a little bit about the natural history of cognitive impairments in MS? Do they get worse? Do they stay the same? Please tell us.
Sure. We're still learning a lot about cognitive impairment in MS, and there's still a lot left to be learned. In general, the earlier in the disease process, the cognitive impairments start out fairly subtle, and they develop over time. The patient normally will come to the clinic on one of their clinic visits, and they will start complaining at some point about cognitive deficits if they do indeed start to present themselves. And at that point, that's when cognition starts to be assessed and tracked over time. The cognitive impairment very often does get worse as the disease progresses. As the disease moves into a more secondary progressive course, the cognitive impairment tends to magnify. And the same is true in primary progressive. As the disease progresses, the cognitive impairment often becomes more significant. Again, though, it is a very heterogeneous population, so that does not happen in every patient. It really depends on the given patient.
What are the real-world implications for patients with MS who do have cognitive impairments?
The implications of cognitive impairment are significant, and they really should not be minimized. It's important for everyone to remember that we use our cognition every single day in everything we do. So when you're driving a car, your attention processing speed, visual spatial perception, your memory functioning, your executive functioning, all of those cognitive realms are active when you're driving a car, as an example. And that's really true for every aspect of cognition. If you're a parent and you're interacting with your child, you have to engage your attention to listen to the child, processing speed to follow along in the conversation, memory functioning to remember what they're saying. Your executive functioning is pivotal to everyday life performance. So if you're in a kitchen and you are, as an example, making dinner, you may be making the salad while you're also cooking something on the stove, and you have to monitor those two things at the same time. You have to make safe decisions. So your executive processes are critically involved in your everyday functioning. So when a person has a deficit, it could have a wide impact on multiple aspects of their daily life.
Can cognitive changes in MS affect employment status? Can it affect family relationships? What kinds of things can it affect in a person's life?
Cognitive changes have a significant impact on employment status, and much of the work that we're doing at Kessler Foundation focuses on employment and the decision of the patient whether to continue employment or cease working. So one of the important factors that some of the researchers at Kessler are looking at right now is personality and the role of personality in employment, as well as self-efficacy. And in addition to cognition, cognition obviously has a big impact on employment status. And cognition plays a significant role in a patient deciding whether to stop working or to continue working. In fact, up to 80% of persons newly diagnosed with MS will stop working within the first 5 years of their diagnosis. And the decision to stop working has a significant impact on overall quality of life. So that's an area where I think we need a lot more research to try to get patients to continue working. The other area you mentioned is social relationships and family relationships. And in many populations, it has been demonstrated that cognition has a significant impact on a person's ability to maintain social relationships and to have fulfilling family relationships. Deficits like difficulty with executive functioning could have a significant impact on your ability to interact with other people effectively and manage relationships over a period of time.
Mm-hmm. Now, MS has been traditionally thought of as a disease of adults. So, does MS occur in children, and do children demonstrate cognitive impairments as adults do?
Increasingly over recent years, we've recognized that children do present with multiple sclerosis. And there are pediatric MS centers that are popping up around the country that are beginning to specifically assess and diagnose multiple sclerosis in children and then maintain their care over a period of time. Children do present with cognitive deficits, and in children those cognitive deficits have to be dealt with very specifically because they are in an environment where they're learning new information every day that's going to be used for their entire life.
Mm-hmm. Okay. So let me ask you then, what do you think the future holds for understanding cognitive problems in MS? What don't we know about cognition in MS to date?
I think we've made great strides recently in understanding cognition in MS. I think a lot of that is due to our new neuroimaging techniques. Neuroimaging is playing a tremendous role in our ability to understand the deficits that we're seeing in persons who have MS and to treat those deficits as we move forward. I think as the imaging technologies improve, we'll improve our understanding of the deficits. One of the things that we really need to do right now is focus on the interaction of different aspects of cognition. So when someone has a processing speed deficit, what does that mean about other aspects of their cognitive functioning and their daily life? And how can we appropriately assess daily life to most effectively diagnose them and then move on to treatment? So Fred, I've spoken a lot about cognitive deficits in MS and what the cognitive deficits are. What happens in a clinic setting when a patient comes in and they are talking to a neurologist? How are cognitive deficits recognized?
We did a study a couple of years ago to find out what neurologists and MS specialty practices are actually doing in terms of screening and assessing for cognitive problems in multiple sclerosis. And what we found was that there were very few screening techniques in place that seemed to have reliability and validity for MS. The majority of MS expert clinicians use their clinical skills and intuition and interviewing to attempt to assess whether or not an MS patient has cognitive impairments. But we know from the literature that those methods are relatively ineffective. So one of the big emphases that we and other people have been doing is developing reliable and valid screening techniques to be able to let the clinician in the very busy clinic setting pick up on these problems so that then they can be properly assessed.
So when you say screening, what do you mean by a screening technique?
There's a difference between screening and assessment. In screening, you want to be able to pick an individual with a very brief test out of a group of people for further assessment and perhaps treatment. For example, medical screening we're all familiar with, such as the Pap smear for cervical cancer, or mammography for breast cancer, or the PSA test for prostate cancer. These are screens. They do not indicate a person has a disease. They just indicate at-risk individuals who then are sent for further testing. So for cognitive problems in MS, this has been a big problem. We have not had reliable and valid screening tests to pick out those people who are at risk or actually have cognitive impairments. So one of the challenges that we face is that in MS patients, their ability to have a conversation, to carry on a normal conversation, can be quite intact. So they can be relating to their neurologist and their nurse and the staff quite easily and fluently, and yet be demonstrating cognitive problems that could be affecting their lives and jeopardizing things like their employment and family relationships. So these problems are hard to detect, which is probably why most MS clinicians have not been able to put in place effective screens.
So who, at a typical MS clinic, who would conduct that type of a screening? Does the neurologist do it, or is there a nurse practitioner, a neuropsychologist?
It depends on the center. Most of the MS care, at least in the United States, is delivered by community neurologists that do not have a large staff. They may have a neurologist and several nurses, a couple of neurologists, but they usually don't have on staff neuropsychologists and other experts that would be able to assess these problems. That represents another challenge in screening for multiple sclerosis and making it widespread. But before we talk about those screens that have been developed recently that can help detect these problems, perhaps first we should talk about, well, what is neuropsychological assessment and what takes place during a neuropsychological assessment? Because I think that will lend a little more clarity on the difference between screening and assessment.
And that was actually my next question. When you screen someone, what happens when the screen shows up positive? So they do have a potential cognitive issue. What happens next? What is the neuropsychological assessment and what's entailed?
Okay, the traditional neuropsychological assessment is a very lengthy procedure that typically could take 4 to 6 hours just to administer the tests to the patient, because the assessment tests all areas of cognition that are relevant to the particular case. So part of it is a psychiatric interview. Does this person have depression or anxiety or another neuropsychiatric disorder that could be interfering in their lives? So that's very important to have that good screening, that good assessment in place. Secondly, it'll take a thorough history of the problems and a thorough family history, a thorough psychosocial history will be taken as well. Then there's extensive psychometric testing that will assess discrete neuropsychological areas such as attention, verbal learning and memory, visual learning and memory, executive function. So all this taken together is lengthy, takes a long time, and is costly. So, and there are not many neuropsychologists available to every community neurologist who is treating MS patients. Thus the need for finding patients, targeting them more precisely who have cognitive problems. And that leads us to talk about the screening next.
So Fred, now that we've talked a little bit about neuropsychological assessment, what happens when a patient comes to a clinic? Do they know that they have a cognitive impairment?
That's an interesting question, because most of the time patients with MS cannot tell when they're becoming cognitively impaired. And this is a very serious problem, because things start going wrong in their lives because of their cognitive problems, and yet they can't tell and frequently cannot understand what is going wrong in their lives. There have been a number of studies developing self-reports of cognitive problems in MS, but unfortunately all of these studies just serve to prove that persons with MS cannot tell when they're becoming cognitively impaired. The majority of the time, when patients think they're becoming cognitively impaired, they're actually becoming clinically depressed. When you're in a state of clinical depression, your mind feels fuzzy, you lose attention and concentration, you feel that everything is going wrong. So they come in saying they can't think clearly, and then when we assess them, we frequently find out that their cognition is fine, but that they're depressed, and then that leads us to, of course, treat their depression. So one of the challenges in screening is that an expert MS clinician cannot really effectively tell when a patient is beginning to develop cognitive problems, and the patient themselves don't know and can't tell when they're beginning to develop cognitive problems. There is some research that has shown that close family members of people with MS are better able to tell when cognitive problems are beginning to emerge in the person. But unfortunately, in the clinic setting, many patients do not come in with close family members, and we don't have the opportunity to ask them. So the dilemma is we want to be able to screen objectively. We want to catch the cognitive problems early, before people lose their jobs, before it disrupts family relationships. But the question is, how do we do that? So recently, there have been some projects that have taken objective, longer neuropsychological tests and shortened them to see if they would serve as very brief, effective screens. Because as you know, in a busy clinic setting, there isn't time to pull a patient aside for several hours and give them tests. So this work has recently been published and have found that, for example, to detect verbal learning and memory problems, we can now shorten an objective test from about 30 minutes to about 3 minutes. And with 98% accuracy, detect patients who will have a problem with verbal learning and memory. So this is very important in terms of its applications in the clinic setting to give neurologists and nurses and frontline clinic staff something brief that they can administer and with a great deal of accuracy detect a problem in memory in MS. We started this work focusing on memory because there have been studies lately that have shown that verbal learning and memory is more highly associated with loss of employment status than other cognitive areas in MS, even though, as you said before, processing speed is clearly, the underlying most common problem in MS. It may not just be as strongly linked to employment status as verbal learning and memory is. So we started there and then have extended the work in developing other shorter, valid objective tests. And so ultimately we now have the ability within just a few minutes in the clinic setting to test the patient quickly, and then if they test positive on this, to send them for a more comprehensive assessment. Remember, there's a difference between screening and assessment. We need to still do a comprehensive assessment on the patient in order to define their cognitive strengths and weaknesses, and in order to determine vocational planning or referrals for cognitive rehabilitation or possible referrals for psychiatric problems. So we don't want to replace the comprehensive assessments with the screenings, but we want to be able to quickly, efficiently pick out those people who are at risk in the clinic setting.
So do you suggest that all patients undergo quick screening?
Yes. At this point, we believe that patients who come in, say, for an annual appointment to the MS center or the clinic should, during that appointment, be given a quick screen of their cognitive function in order to identify if this is a problem that is beginning to emerge, so that potential interventions can be done, before significant problems in their life or their employment status emerges.
So for a screening, we're talking about how much time, like 10 minutes every year? Is that?
It could even be less than 10 minutes. We have shortened a number of tests, including a brief test of processing speed, so that if you had to pick just a couple of tests to look at the potential emergence of cognitive problems in MS, one would probably pick a shortened test of processing speed, the symbol digit modalities test, which you mentioned before, and the shortened version of the California Verbal Learning Test, which shortens the time to just a couple of minutes. There are other cognitive tests that can be shortened as well that we have found, and the reason one might want to kind of give all of them is that sometimes cognitive problems in MS are focal. That is to say, you can have a problem in one area but not another. So if we gave the test of verbal learning and memory Well, perhaps that patient has a problem in processing speed, or a problem in visual learning and memory, or a problem in visual judgment or in executive functioning, which is like being able to plan and organize and have cognitive flexibility in the way one approaches tasks. So the shortened screening battery, all told, will take about 12 minutes to give to cover the major domains of potential cognitive impairment in MS. Now, when I speak to many clinicians, they say 12 minutes is too long. We don't have 12 minutes to be able to give in the clinic setting. So if that's the case, how about 3 minutes? Just select the shortened versions of the test for processing speed and perhaps verbal learning and memory, and in just a few minutes, you can, with very good accuracy, determine whether or not this person is at risk or has cognitive problems.
What are the advantages of screening the patients?
The advantages of screening the patients is that you can accurately detect impairments. Up until now, the neurologist or the patient would complain, the neurologist would make an observation, the patient would complain about cognitive problems, and based on many factors, they would be referred for neuropsychological testing. However, many of those referrals are not accurate, and the patient actually does not have cognitive problems. So when one is doing screening, there are two important concepts to keep track of. One is the sensitivity of the screen, and the other is the specificity of the screen. The sensitivity of the screen answers the question, how many actual cases are you picking up? So say, for example, out of 100% of impaired patients, your screen is only detecting 60% of them. That means the sensitivity is 60%. You're missing 40% of the true cases. Specificity kind of refers to the idea of, well, how many people are you screening and overestimating the problem with? So you want a test and a screening test that optimizes the sensitivity, that is picking up the true cases and not missing many, with specificity, which is not overestimating, picking up people who really do not have the problem, but sending them on for further assessment. So that's very important, and in these brief screening tests, the sensitivities and specificities are very, very good, and better than in most tests for picking up other medical problems, such as the PSA, the pap smear, mammography, etc.
So it sounds like a good screen really helps us allocate our resources more effectively.
Yes, that's a very good point. Time and money in the clinic setting are precious commodities, and we do not have the ability to do a comprehensive neuropsychological assessment on everyone who walks through the door. It would be a waste of time and resources and not possible. So these new screening approaches can much more effectively pick out those people who need the further assessment without too much overestimation or too much missing of the actual cases.
So, Fred, if you're administering the same screening battery on an annual basis, is there an impact of the patient repeating the same test over and over again?
That's an excellent question. With neuropsychological tests, there is a learning effect. Patients will tend to do better slightly on the same test over time. There are several things that can be done about this to minimize the learning effect. One is not giving the exact same test, giving what we call alternate forms of the answers, of the required answers to the patients, so that will help minimize them remembering the exact same information, because the information that they'll be required to produce and reproduce will be a little different. We need to do more studies on this practice effect in MS if we're going to do routine monitoring of screening tests in the clinic setting. For example, the symbol digit modalities test, which you mentioned before as measuring processing speed in multiple sclerosis, has been administered in very large-scale studies in Europe and North America every 4 months for up to 48 months to examine the practice effects. And indeed, patients worldwide do a little bit better each time on this test. about a 1.5 point difference of improvement when they take the test over and over again. The practice effect does not increase over time. So that leaves the clinician wondering, well, suppose there's no improvement. Does that mean there's a cognitive problem on this test? Or suppose the patient goes down a couple of points on this test. What is the clinician supposed to do with this information? And we need to do more research to find out what clinically meaningful changes are in these tests over time. With the symbol digit modalities test, for example, it has been found in research that a 3-point drop on the SDMT is associated with a clinical exacerbation of their multiple sclerosis. So at least for that one test, we can anchor a 3-point drop to a clinically meaningful change that should warrant intervention on the part of the neurologist. But we need to do research on these other tests in the screening battery to find out what are clinically meaningful changes and what's the neurologist to do, if there is no practice effect or a minor drop on the score. So, Nancy, now that we know that cognitive impairments are very common in MS, and we know that they can have a profound impact on many aspects of patients' lives, and now that we know how to screen and assess these problems in MS, that really leaves the question, well, what do we do about it? What can be done to impact cognitive problems in MS?
So traditionally, when a patient has a cognitive problem, the intervention is cognitive rehabilitation. Cognitive rehabilitation is designed to improve patients' cognition. And you could do cognitive rehabilitation in various areas of functioning. There are programs that have been developed in attention, in executive functioning, in learning and memory, in working memory. The challenge is identifying cognitive rehabilitation protocols that are effective and demonstrating that they are effective in a particular patient population, such as MS. So in multiple sclerosis, we see that learning and memory, as an example, is a major problem in individuals who have multiple sclerosis. So much of the research that we have done recently at Kessler Foundation focuses on an intervention for learning and memory functioning, the modified story memory technique. We now have 5 publications out that demonstrate that the story memory technique is effective in patients with MS. We have behavioral data demonstrating its efficacy. We have data showing that it has an impact on a patient's everyday life functioning. And then we also have neuroimaging data demonstrating that this technique is actually changing the way the brain is functioning when it's learning and remembering information. In addition, many of these studies show that over a 6-month period, that the effect of the treatment is maintained. So patients aren't losing the effect over time. The effect of the treatment is being maintained over a 6-month period, which is fantastic for the patient to be able to maintain the gains that they have achieved. The rehabilitation protocol is a 10-session treatment protocol that teaches the patient how to use context and imagery to facilitate learning. So what that means is the patient is taught to associate verbal information with images. Our imaging data is showing us that what's happening is that we're engaging different areas of the brain in assisting in remembering that information. And then the patient is also taught to organize the information and putting it into a meaningful context. The combination of that context and that imagery is facilitating improved memory functioning for this group of patients. Part of the treatment protocol also focuses on the generalization of the treatment to everyday life. So 2 of the sessions actually teach the patient how to take the techniques that they're learning and apply them in their everyday life. So when we identify a deficit in cognition, there is definitely something that we can do about it now. And there are more and more techniques like this being developed that we're identifying as being helpful for persons with MS.
That's amazing that in 10 visits, you can significantly improve memory problems in MS, and that's reflected in the MRI metrics in the brain. But suppose you refer to patient. MS patients have many complex problems. Suppose we identify a patient who has a verbal learning and memory problem, but they are also depressed and very fatigued, and we send them to your clinic, to get this approach. What would you do with a patient like that?
I think that's a great question. So the first step with any patient is the neuropsychological evaluation. And through that evaluation, that's when you can identify depression as a problem, fatigue as a problem, and potentially learning and memory, like in the patient you described. The next step then is to figure out which problem should be most efficaciously addressed first. So we know that there are effective treatments for depression. So perhaps putting the patient on an antidepressant, initiating them in psychotherapy or in group therapy or whatever that particular patient needs to address that depression might be the best place to start, and then examine the impact on fatigue and on learning and memory. Another way to address an individual like this, though, and this is really a clinical decision based on the patient themselves, is to address the depression and also at the same time address the learning and memory issue. So you're attacking the problem from two vantage points at one time, and then after that examine their learning and memory abilities, and then reassess their depression and see where you stand at that point.
Mm-hmm. In addition to the story memory technique you've been mentioning, are there other rehabilitation techniques that can improve cognitive functioning?
There are several other neurorehabilitation techniques out there. The RehaCalm is a rehabilitation technique that has been used substantially in Europe, and they have some very nice efficacy data showing improved attention, processing speed, and executive functioning after treatment. So that's a program that's available out there as well. We're also working on another program called Speed of Processing Training that addresses processing speed in particular. We have strong pilot data showing that it can help patients with MS with their processing speed deficits. And there's tremendous data out there in a normal aging population from Carleen Ball at the University of Alabama that demonstrates that the processing speed intervention is effective in normal aging. So we expect that we're currently running a full clinical trial on this in MS, and we're expecting that the data will give us some great findings in regard to its efficacy specifically within MS population.
Interesting. Off on a different note, we frequently hear about this idea of cognitive reserve in the aging population as something that can forestall the onset of Alzheimer's disease, clinical symptoms. And what is the importance of this idea of cognitive reserve in multiple sclerosis?
So what cognitive reserve is, the theory of cognitive reserve states that when someone has higher intellectual enrichment, higher intellectual capacities, they're able to stave off the cognitive decline longer. So when someone is diagnosed with MS, if they have a higher cognitive reserve, they are less likely to show symptoms until later in the disease process. What that means for MS is that persons who have that higher cognitive reserve will not show those cognitive deficits as early as someone who has less cognitive reserve. In regard to actual intervention, that's something that we're looking into now. So one question that remains is, when someone is initially diagnosed, can you boost cognitive reserve? Knowing that cognitive deficits are likely in that person's future, can you intervene when they're diagnosed, increase their cognitive reserve so that hopefully you will stave off that cognitive decline until a later point in time? And that's something that research is currently being designed to answer.
Your studies and other studies on cognitive rehabilitation have found that you can make significant improvements that are meaningful on neuropsychological testing in everyday life and on neuroimaging. Would you say that intervention techniques such as you're using can improve someone's cognitive reserve?
So I think what the intervention techniques we are testing are doing is engaging additional areas of the brain in performing a function that may have previously been accomplished by a more circumscribed area of the brain. So as an example, with the story memory technique, we're giving people a list of words and we're asking them to remember that list of words. During the training, we're teaching them to use imagery and context to help them remember that list of words. When we look at the neuroimaging, we know that they're using imagery because the areas of the brain that are typically involved in imagery are more active after treatment. So what we believe we're doing is that we're engaging that additional brain region to help support their memory functions, and that's resulting in a behavioral improvement. So rather than, I wouldn't say we're actually increasing cognitive reserve. I think what we're doing is engaging additional brain regions to help support a function that may have only been previously accomplished by one brain area or fewer brain areas.
So in your work on increasing cognitive reserve, how are those exercises or challenges different from those that are just remediating, one area of function such as verbal memory?
That's a good question. I think when you're trying to increase cognitive reserve, what you're doing is working with a patient who may not necessarily have cognitive deficits yet. What you're doing is taking a newly diagnosed patient and working with that patient and trying to get them to improve their overall intellectual capacities and their overall exposure to different types of stimulating materials to boost that cognitive reserve. The difference is with a cognitive rehabilitation protocol, you're working with someone who already has a cognitive deficit and you're remediating that deficit. So it's a different time in the course of the illness that you're working with the patient.
What do you see as the most important next steps in your research on cognitive rehabilitation in MS?
What we need to do at this point is develop more cognitive rehabilitation protocols. We have to demonstrate their efficacy through the provision of Class 1 evidence. So we have to conduct large-scale randomized clinical trials demonstrating that these cognitive rehabilitation techniques are indeed efficacious for persons with MS. We also have to demonstrate that they are effective not only for persons with relapsing remitting MS, but also for persons who have secondary progressive and primary progressive MS, because the disease courses are different, and that may impact the efficacy of the treatments. So the treatments may need to be revised a little bit for the different disease etiologies. And I think the other thing we need to do is really begin to understand what is happening at the level of the brain, and that's where a lot of this neuroimaging work initiates. Is we know that there are behavioral changes. We can see them with our behavioral data, and what we need to try to do is understand what's happening at the level of the brain with the goal of increasing the changes at the level of the brain that result in behavioral efficacy.
There have been many changes in neuroimaging in the last decade. How have these improvements helped your research, and do you anticipate further improvements in neuroimaging to kind of give you better evidence?
Well, neuroimaging changes constantly, and that provides us with an incredible resource to be able to understand our treatment paradigms and the effect of our treatment paradigms. So recently, we have for years been doing functional MRI work, pre and post cognitive rehab, and what that has allowed us to do is look at activity in the brain during a task. So we're able to see how patients learn and remember information before treatment and how they learn and remember information after treatment. And that provides us with a lot of evidence of efficacy of the treatment. But newer techniques have also developed where we're able to look, as an example, at functional connectivity or how the brain networks are interacting with one another. And what we're starting to see from before to after cognitive rehabilitation is that connectivity increases over time. So there's increased communication within the memory system that's resulting from treatment. The other thing we're able to look at now is white matter changes more specifically, and looking at changes in that white matter over time before and after treatment to be able to more definitively identify exactly what the neuroanatomical impact of these treatments are. So I think as time goes on, more imaging protocols will be developed and applied, and we'll be able to answer more and more of our questions to help us truly understand what is happening during cognitive rehabilitation.
In summary, we know that cognitive changes in multiple sclerosis are widespread. Up to 70% of persons with multiple sclerosis will have some cognitive changes over the course of their illness. We've also been able to very accurately categorize those impairments with objective, reliable, valid neuropsychological tests in meaningful ways. More recently, we've been able to develop screening tools that can be quickly used in the clinic setting to identify patients who are at risk for cognitive changes. Cognitive changes can have devastating effects on a person's life, on their employment, family relations, and finances. So it's important to be able to identify people at risk quickly and easily in the clinic setting. And these new screening approaches seem to be able to do that much better than all previous approaches, including expert MS specialty interviews and patient self-reports. In addition, once a person is identified as having a problem with cognition in MS, we now know there are many options for what we can do to help that person and improve their life. We can give them vocational retraining. We can refer them for emotional support if we detect that there's a depression or other neuropsychiatric disorder present, which also happens with greater frequency in persons with multiple sclerosis. Importantly, recent research on cognitive rehabilitation has found evidence-based approaches that can improve cognitive problems in multiple sclerosis that is reflected in both objective neuropsych test improvements, changes in everyday life that are meaningful to the patients, and in functional connectivity and other markers of functional magnetic resonance imaging in the brain. So the future is looking brighter and brighter for understanding, detecting, and treating cognitive problems in multiple sclerosis. Thank you very much for being with us today.